each of us was able to. So I will be facilitating and again trying to lead us through this agenda today. So. Nope. Nope. Oh my goodness. Yeah. No problem. Well, and we kind of made some changes after our first capacity committee meeting. We, Representative House and Sally and I decided the three of us would co-chair. But what was the word, Jean? I was thinking you came up with a cuter term than co-chairs, but someone had. But anyway, so we're going to share those responsibilities as we work our way through this. Okay. No problem. Thank you. I am kind of looking at the people that are already on. I think in the essence of time, I would like to go ahead and get started if everybody's okay with that. So welcome to everybody this morning. Again, I'm Leanne Smith. I am the Director of Residential Services and Public Relations at St. Francis Senior Ministries here in Tiffin, Ohio. So I represent this group as a family member of, my mother had Alzheimer's, and I'm on this task force to hopefully bring some insight as a family member, a caregiver, and also working in this industry. So welcome to everyone this morning. I'm not sure if we need to do introductions of everyone or do a roll call. Is that something that we need to do each meeting, or? Right. I am officially calling this meeting to order, and I guess we'll go through who I'm seeing is currently on this list. Sarah, obviously. You're present. Jean Thompson.
Present.
Joe Russell.
Here.
Alex. That's what this week.
I'm here. Good morning, everyone.
Pete Van Runkle.
Here.
Okay. Representative Rodney Creech.
Here.
Senator Wilson. Not sure.
Senator Wilson has a conflict. He's excused today.
Okay. Sally Bolin.
Here.
Okay. Representative House.
I'm here.
Okay. Have I missed anyone? Okay. Well, we'll officially start the meeting then, call it to order. I think our first order of business is to approve the previous meeting minutes. Has everyone had an opportunity to look over those? And hopefully, if so, are there any changes, corrections, or additions to those?
Look good to me.
Okay. All right. Hearing none, I'll ask for a motion then to approve those minutes.
So moved.
Okay. Second for that.
I'll second that.
Okay, thank you. Any other discussion on those? Oh, okay. We'll approve the previous meeting minutes. Thanks to Jean and your helper who took those for us. They were very well done. Thank you. So I think the next thing I see is the review of our agenda format. Is everybody okay with the way this agenda is looking? I know that Sally was, very instrumental in putting this agenda together, and I think I'd like to just keep following that if everybody's okay, or is there anything else that we should change or add to this agenda? No, everybody's good?
Looks
Okay.
good.
Okay, good. All right. Probably the biggest thing we need to discuss then today is this homework assignment. We had discussed at the last meeting, specific numbers on the Senate bill topics to, give our input, look at, make comments on, all of that good stuff. So I guess we'll just go down through them. One of my questions was, as I was looking through that, I saw yours on the share file. If someone else has theirs on there, I apologize. I looked at that yesterday and I haven't looked at that again this morning. But is that going to be the best way moving forward for each of us to put our comments on the share file so that we can all see what everyone's thinking? Or how does this group feel it's best to kind of organize and compile our thoughts on this homework? Anybody have any?
Actually, I do, Leanne. I think it's important that we're never going to make progress or move forward unless we do have people put in comments ahead, given the very short time frame we have for anything, even if it's just organizing what it is we want the consultant to do. But I think it probably, in the interest of time, basically last meeting we got through one. So if you took that, in terms of all of them, we are not going to make enough progress. So I think it's actually helpful if people do those.
Okay.
Leanne,
least
this
it
is
moves-
I'm sorry, go ahead, Jean.
Well, I just meant it moves us forward, at least some.
I agree. Sally, you had
The only thought, I had, because I know I wrote on a separate document, and the one thing I wondered about, and maybe that's not for us to decide and we just submit it. However, I thought for a minute, I started typing on Jean's document. I'm like, wait, I shouldn't do that. And so I started a separate one. And I know our committee's not that big, so maybe it's manageable if we all have our own documents and submit it. I didn't know if we wanted to do a working document, kind of like, how in Google Drive and different things you share things. But, that was the one thing I wondered about. So is all of us putting it in somehow with track changes or something? I don't know. That was the one thing
I would say that if we all put it in, then the working document can be what the group decides from those individual suggestions, etc., comments of people should be in the working document. But it gives us a place to start. That's just my thoughts, that if everybody individually says what they want, the working document then can be the compilation of what actually the group thinks.
okay. So maybe the working document would occur after we've gotten through each point and everyone, and then, maybe those of us that are the facilitators or the co-chairs could try to somehow organize then everybody's, comments or points. Would that make sense to kind of get through them all first, have everybody put their input in, and then maybe by that time, I saw Alex's email that the RFP has gone out. Would that seem like
I think that makes a lot of sense, because then we at least have something that we can share with the even broader group that is a compilation of the subcommittee's feelings, suggestions, comments.
Right. I agree. I think that will help, like you said, keep us moving forward and, keep things organized. So, I guess I'm sorry, go ahead.
I'm sorry. I thought you were finished, Leanne. So go ahead and finish your statement.
No,
You're
good, Pete. You're fine.
I was just going to say two things. One, I believe, and I just want to verify this. Last time I volunteered to take the notes, so I was kind of doing that. But if that's not, I want to just confirm that to make sure I'm not wasting my time here. So,
I'm sorry, Pete. Yes, you are
Okay.
on the hook to take our minutes.
okay. All right. Well, I have no problem with that. I'll get her done. And then secondly, as it relates to the subject we were just on, I'm fine with that. But for today, I mean, we hadn't arrived, I don't think, at that approach previously. So I didn't go in and put anything into the document. I haven't even been in the share site. I thought we were going to walk through them, try to do it more quickly than we did the last time. We were going to walk through the next, what was it, 4 that we had chosen to cover, and throw our comments in there now, and go from there. We can switch over to the other approach, but I think at this point we're not there yet.
Yeah, I think that was just kind of my thoughts as I was reading through Jean's comments on the share drive, and as I was looking at the different topics that we need to cover. I think you're right. This is kind of new to this meeting, but I do think we can still go through those today. We can try to go and get people's comments, but then ask the group if they have a chance to, just put those on the share drive, so that at some point those can all be compiled as we work with the consultants or the company that's going to come in and help us further. Does that?
Yeah, I think that'll work. That'll work for moving forward. Now that we know what process is, so that's cool.
Yeah, I just was trying.
I just did mine early because, sometimes I'll have more time than other times. So,
I just forgot. I ain't gonna even lie. So I just put the little notes in my notes section. I was like, oh, we do got a share drive. So yes, now I'm on it. I'm on it.
Yeah. Jean, I kind of took your lead. I'll be honest. I think that was a great way to do that, and that's kind of what made my, thoughts head that direction. So hopefully, if that works for everybody, that, certainly everybody's busy, but if you're able to get some comments in there on the share drive, and then we can see what everybody's thoughts are. But okay, so I think then we'll start going through these. Do you want to start? What I was looking at was we had 1, 2, 3, 4, 5, 6, 7, and 8.
I thought we were kind of done with 1, though, Sally. We spend a lot of time. I was really focusing on 2 through 8.
Okay, so we're done with 1. That's good. That's where I thought we were at. So 2 is the state's policies regarding individuals with Alzheimer's disease or related dementias. I feel like there are resources out there that probably know those policies. Anyone please here on this this meeting, please jump in there and feel free to start this conversation, because I can be familiar with what goes on at a local level in a local facility, but as far as the state's policies, that's pretty broad. So, Jean, I know you had some good comments on that. I don't know if you'd like to maybe.
Can you read them, Leanne? I don't have that in front of me. I'm on a different computer than normal.
While you're pulling those up, Leanne, I know I was thinking, I know that there's been a couple task force previously in Ohio. And so I had thought I'm not sure what came from the last task force. Nothing did. Okay. I know that there's, been a long time ago, because it was actually my state rep. So I'm going back 20 years, who started the Alzheimer's respite line item in the budget. His name was Barney Quilter, and he's since passed. Pete, you're smiling. You know Barney too. He's a great man.
Yeah.
So, but
and his wife had dementia, so
right,
very
she did.
Close to this issue.
Yeah, she was very close to it. It was very near and dear to his heart. So, I had 2 thoughts about this. One is, looking through what's been done previously, because why rebuild what we've already done in Ohio? But then I know that, and there's a resource at the federal level through the Administration on Community Living, and there are several states who have really interesting models about state policies and even how they address this whole issue of dementia. Like the state of, and they have very different models too. Like in the state of Washington, the state government takes a lead. And
Shoot, I'd ask you.
it's really a true
I
collaborative.
put my head out the door.
Oops.
I'm getting ready to head down there if you want to go.
Right, I think somebody needs to be on mute, please.
So,
Thank you.
so I was worried I was talking over someone. I hate to do that. Sometimes I do. The state of Washington has an interesting model where the state government leads a dementia collaborative. And I'll put this in the file. In the state of Minnesota has a whole group of individuals. I think what's kind of neat about these groups and then the policies and programs that are coming out of it is it's really a true collaborative. And so different organizations and individuals are bringing different expertise and experiences to the table. But there are some interesting, and so my thought was to look what's out there already and what's been done in Ohio previously. And I don't know if I know all that, but it seems like that makes sense from a consultant standpoint. So that's, I hope that helped Leanne find the document you were looking for. So,
Yes, I just was pulling up Jean's comments on the shared file. I think that sounds like a great resource. I'm sorry, go ahead, Jean.
No, my apologies. Leanne, maybe we could, and I don't know if this is in the format, but if Alex is our state liaison, like with aging, maybe there we could task him to come up with what he believes are any Ohio current policies. Then we could ask the consultant to bring forward sample policies from other states that we might look at. That would just sort of get us there then, in combination with all the things Sally said. And I think that's really what I said pretty much on on my comments.
Okay.
But it gives us an actual direction and move. I mean, I don't know.
Hadn't we determined somewhere along the line that Ohio is one of only a handful of states that doesn't have a state plan?
Yeah, we don't have a state plan and we really don't have any policies. I mean, outside of like the respite care, we have a recognition month, but in like our actual statutes, let me say, we don't have any actual laws. Let me put that one. So there may be some policies, but maybe we need to dig a little deeper to go in there. I think that's probably one of the larger issues here is that we don't necessarily have I would say very clear things for our a broader lay person to understand kind of what is happening in Ohio. I'll put it that way.
Okay. So do you guys feel then this is something do you still want to move forward with having Alex look and see what's out there? Or is this something that we need to wait until the consultants get on board and kind of tell us what's out there?
Yeah, I also could think, I know there's been at least 2 task force while I've been in the General Assembly. And so I know somebody had brought that up about bringing the suggestions forward from at least those task force. I could bring those forward. I don't know. I see Alex came on camera, so I don't know if he wants to chime in. Hi, good morning, Alex.
Good morning, everyone. Nice to see you all. Yes, so I will go ahead and check with my legal team. Outside of the Alzheimer's respite line and some of the methodologies associated with distributing those funds, we'll have to look into what other state agencies may or may not have relative to dementia-related policies. One conversation that I've had with Trey Addison with the Alzheimer's Association is his team has collected what other states have done relative to this work, to their state plans, the task forces that they have established in order to adopt a state plan. Some states have been very effective, others not so much. And so maybe this is an opportunity at an upcoming meeting we could solicit Trey and his team with the Alzheimer's Association to maybe provide some additional documentation, but perhaps maybe a short presentation as well that kind of looks into what other states have done, what other states have maybe learned from others. It is my understanding that some states are going back to the drawing board. Their initial work was a little incomplete. And so looking at what other states have done, they've kind of looked themselves in the mirror and identified, look, we could have done more, we should have done more, so we will be doing more. And so maybe that is something that we can consider as well. And that being an opportunity to have Trey or members from the Alzheimer's Association come to this committee to present on what other states have done.
And then I would say, in addition to that, one of the things that we do have access to is the National Council for the National Caucus for State Legislators, as well as the Council for State Governments. And I know both of them have had some, like some reports and some analysis, definitely CSG on the Midwest states in Alzheimer's and dementia. And then we could just reach out to NCSL. And so I will follow up with and maybe try to divvy up some of these responsibilities with the other legislators so that we can put out some requests to them to see what we can compile, to add to this conversation, if that would be okay with the group.
Rep House, I think that would be fantastic. You have that unique connection and relationship with those two key groups that can provide those comparison documents. So that would be really helpful.
And Alex, I don't know if ODA has a contact at the Administration for Community Living, but the National Alzheimer's and Dementia Resource Center has compiled a lot of things too through ACL. Because they're managing all the federal grant programs that are going to the states. So that would be another really great resource too, I think. So.
Yeah, absolutely. I can check with Ashley Davis. She's our lead contact over at ACL. Mm-hmm. So I can go ahead and solicit her and see exactly what type of information we might be able to get.
Wow, well, this sounds wonderful. What great information it sounds like we can gather from all of these different resources. So I think we can probably move on from number 2, but how would you guys like to, again, compile all of this information for those of you that are going to be reaching out to different your different resources?
We talked about putting it in the shared drive, correct? So that's,
right.
I think, just for right now.
Okay.
We can always clean it up later, but once we're getting information, just put it in the shared drive. And if you have any questions, because for me, I haven't even looked at it, I'm gonna be honest. So once I, look at it, whatever, just put it, and I think the biggest thing is labeling it according to the document we have. So this is point number 2. So, you know what I'm saying? Put your name with point number 2 and just add it in the shared drive.
Okay. That sounds great. Moving forward, that'll be wonderful. Is there anything else that you would like to talk to? I'm just trying to kind of move through this today, but is there anything else with the number 2 that anyone else would like to comment on or talk about before we go to number 3? Okay. So number 3 is the fiscal impact of Alzheimer's disease and related dementias on publicly funded healthcare programs. Wow. Again, Jean, I don't know if you want me to read what your comments were on that.
Could you? I don't have that in front of me, and I can't really remember. I did go through all of them early, last week. So I don't really. I should have had that. My apologies with me this morning.
No problem. I've got 2 computers up here, so I'm going to back up a little bit, and I'll just read to you guys. You said the Alzheimer's Association, just, from some information below, perhaps this should be a consultant issue. You talked about as baby boomers advance in age, the numbers create a frightening scenario, according to the Alzheimer's Association. An American develops Alzheimer's disease every 68 seconds, a figure expected to increase to every 33 seconds by mid-century. projections, suggest that as many as 16 million will have Alzheimer's disease by 2050. Those are just the first few points that you had made. And it goes on to just talk about the numbers of people, the impact that it will have. Americans aged 65 and older, 1 in 8 has Alzheimer's disease, while nearly over half of people aged 85 and older suffer from it. Those are big numbers. The annual cost of caring for individuals with Alzheimer's disease, or the economic value of unpaid care for Alzheimer's patients, has reached $200 billion, according to Matthew Bumgart, Senior Director of Public Policy for the Alzheimer's Association. That figure can be broken down into 4 segments. Governmental programs in the form of Medicare and Medicaid spent $104.5 billion and $35.5 billion, respectively. Another $33.8 billion is attributed to out-of-pocket expenses, and another $26.2 billion originates from private health insurance, HMOs, and other uncompensated care. The economic value of unpaid care for Alzheimer's patients is often provided by family members, friends, and neighbors, and it's estimated at $210 billion, while the cost of health care provided by paid caregivers is $8.7 billion. And that's an economic burden, obviously. The economic impact of Alzheimer's disease patients on Medicare and Medicaid compared with older adults without Alzheimer's disease presents a startling eye-opener. Bumgart notes that in 2008, the average annual per-person Medicare payment was $7,621, while the average annual per-person payment for patients with Alzheimer's disease was $19,820, and that was in 2011. So those are your comments that I found.
They're really, excuse me, Sally, they're really comments taken from the Alzheimer's Association information. So this might be, to me, what's really difficult in that statement that we were to address is the publicly funded healthcare. I mean, lots and lots of this is actually happening that's not publicly funded. And the truth is, we probably cannot afford as a country to publicly fund all of it as we move forward, given those startling numbers in the Alzheimer's Association information, which means that we have to make more resources available, for instance, to those unpaid caregivers, et cetera, and because we aren't going to be able to afford to publicly care for everyone with Alzheimer's.
Right.
Back to the actual question about and trying to assuming that this is really looking at the state. I wonder if it would be possible, and I think this is again more a question for our consultant, but if it would be possible to take the methodologies from whatever the Alzheimer's Association did, where they came up with all of these numbers, they had to have a methodology behind that.
They already have it.
And see if it's been applied to Ohio or could be applied to Ohio to come up with Ohio-specific numbers.
Just to add that they do have some Ohio numbers, and so I will put the link into a report. So when you look at just some of the Ohio things, so they have like the total Medicaid payments for people 65 and older with Alzheimer's or dementia. It is estimated right now that Ohio in 2020, we spent about $2.5 billion, estimated to go up to about $2.9 billion by 2025. So you can look into that. And they have some other things based on like hospice care, some of the breakdowns between, kind of like I would say the average cost from different type of care settings. So there are some things. What I will do is noted in the shared drive and the specific pages where, that could be a reference for people.
And
That's
I think
great. Thank you.
I think that Scripps has some things. I don't know, Jean or Pete, but when Scripps has had their advisory council meetings, their long-term care advisory council meetings, it seems to me that they had some breakdown of things too, maybe by county or by different industries and things like that. So that could be another helpful resource to, I guess, inform number 3 too. So I'll make sure that
I'm not sure. I'm not sure if those were separated out for people with dementia or whether it was more broad. I think that their work has been more about, people with disabilities in general, or aging people in general. And I guess that would be my question. And I apologize if this is clearly laid out, but I wonder how the Alzheimer's Association was able to tease those out. Because you can say, okay, Medicare spent this much money on, a particular service.
Mhm.
That's pretty well, pretty obvious and well reported. But, trying to figure out how many of the people who received that service had dementia, that would be something. I wonder what their methodology was for that, because I don't think that's really obvious on the surface.
I do think I actually talked with Scripps when I was writing my comments for the shared drive. And, Scripps biennially, but we're a little late right this time because of the pandemic, does a longitudinal study. Pete's very familiar with it too, of long-term care facilities, nursing homes and assisted living. And but Jane Straker and Bob Applebaum were saying that the info they have now from the last survey really reflects 2018, which, we're 3 years hence from that. An example being, they said in 2018, there were 233 assisted living communities that either were all memory care or had a specific memory care unit. But they felt that number has climbed dramatically in those 3 years. And they are in the process of doing another one of those surveys. I may have referenced this on the shared drive, I can't remember, but they won't, at the very earliest, and they wouldn't be the official results, they would be maybe able to give our consultant or us some information June or July, maybe more likely, I think July. It won't be their official report in terms of a more recent data.
Oh, that's great. I'm so glad you called them. That's good to know. So.
Okay.
I'm glad you called them. That's great to know. Thank you.
Thanks. Yeah.
Yeah, that's great.
Well, but Pete's right. It is very difficult sometimes to tease out information that's dementia specific.
Yeah.
Although I did get some good info from the state, actually, which I didn't even know they had, that they had how many, I think I mentioned this on the shared drive too. They have the numbers of certified dementia units within the waiver program, which would be the government funded program, obviously. But now all of this is so difficult to tease out because just because they're there, way more units are certified than are actually occupied. So it's because the reimbursement is so low, they're just not putting people in those units.
Right. Yeah, I think you're right. Facilities can be certified for maybe 30 beds to have the Medicaid waiver, but to be able to financially operate, they may only allow 5 Medicaid waiver patients.
That's very common.
Yeah.
And we even have facilities that certified all their beds just to make their lives easier, or before they really understood everything, so that they could move people. It wasn't an issue. But I'm unaware of anyone who's using 100% of their beds in assisted living for the ALW dementia care.
I would agree with that. I'm not aware of any.
I agree with that as well. Well, again, it sounds like we have some great resources to get some answers and information, I guess, on the fiscal impact for publicly funded healthcare programs. I appreciate everyone's thoughts and input and reaching out to other resources to help us, again, see what this impact really is. So any other comments or questions on number 3 that anyone would like to add? Okay. Well, again, put all this on our shared drive. So number 4 was the next topic, and that is the establishment of a surveillance system to better determine the number of individuals diagnosed with Alzheimer's disease or related dementias and to monitor changes to such numbers. It sounded like from our past comment, there are some numbers out there for the number of people diagnosed. I mean, obviously, Jean, your comments, and I think number 2 or number 3, you gave a lot of statistics from the Alzheimer's Association, and we need to kind of dive down deeper into just exactly how these people are being accounted for as they're diagnosed, or that's the way I read that. Not necessarily maybe that they're in a facility, but those who are diagnosed.
I
just
agree.
wonder if some kind of proxy is being used. Like, okay, we assume that the incidence of Alzheimer's and related dementias among people of a certain age cohort is X, and so we're just going to apply X across the board. I don't know that there's really, I suspect that there's probably not any kind of way of actually on an individual basis, counting them up,
Right.
that there's some
Well,
registry or something.
Well, actually there is, but I think there are a lot of social mores that would actually kind of either not permit that, or people, you could actually, there have been cases of certain things where, for instance, a physician, when a diagnosis is made, has to report it. So you could actually do that. But I think there would be a big public outcry, maybe, if you attempted to do that, and physicians would be hesitant to do that. So, and I mean, there might even be, certainly you wouldn't want any kind of names, etc., personal information attached to it, given HIPAA and everything. But I mean, I guess I thought they were looking, when they used the word surveillance, that said to me they were looking for more definitive numbers than what you were saying, like a general approximation. But I don't know if we're ready for that.
So. I think so, and I believe that there is. This just came to mind when you were talking, Jean. I believe that there is one for cancer that ODH has, and that's reported by, I assume, physicians. I'm not. I don't know the details of it, whether it's comprehensive or whether it's limited to certain kinds of cancers or certain cancers that have progressed to a place where the person's hospitalized or something. So, but it is, as I think you said, there are registries of different things, and there could be one of Alzheimer's.
So I feel like, Jean, when you referenced the physicians, it seems like that's where it would almost have to start, that physicians would have to have some type of reporting system, and again, that's another
lot of issues.
Issue.
Yeah.
Yeah.
A lot of issues with that.
And I think people, especially in early onset and those kinds of things, they might hesitate to go for help if they thought it was going to be reported, if in fact you were diagnosed with it. I mean, there's a lot of, so I don't know. I was just trying to respond to the question and their surveillance terminology that said to me they wanted not estimated numbers, but real numbers.
I think that this might bear a little further review of the cancer reporting registry and any other similar registries that are disease specific. I don't know that I don't know how it works if they actually disclose individual identifying information, or if it's like I had a case and it was this kind of cancer. So that might go to some of that concern that you raised, Gene, or maybe it is individually identified and it's just maintained confidentially. I don't know, but I think it's worth as you said. This seems to be pointing at a true surveillance mechanism, which that would really mean getting the actual cases. So we ought to look into that from that angle, I would say.
Yeah, I agree with you, Pete. And you as well, Gene, just with your comments. But that surveillance is a kind of a big word to determine just what that means.
Yeah, I felt the same way, and I would echo exactly what all of you said. I think that, and particularly the stigmatism and associated with this disease, this one tripped me up in regards to, what do we do about this one, but maybe looking at what other states are doing or health systems and I know that there's been a couple of studies that have come out that, physicians are hesitant to give the diagnosis because they don't know what to do about it. And so I understand the importance of capturing numbers, but you question then where the numbers are coming from and, what do they actually mean? And so
maybe this is a great one for us to ask for the help of a consultant to find out if any other states do have a surveillance model, or as Pete mentioned, they could look at what Ohio does in certain other issues. Although I do think the stigmatism, as you pointed out, Sally, is much bigger in this than in a lot of other more medical issues. So, but that would be to me, that's the purpose of our going through all this, is to have a list then of what we want help from the consultant on, and can sort of based on that, or from other members of the group, like Representative House said, look at and then compile this working document that moves forward.
Yeah.
So a couple of things. Well, first, I think it should be a recommendation that we need to change the language just because of the whole surveillance thing. I don't think it's just necessarily appropriate, and it may not necessarily get us where we want to go. That's right. Just a thought. The other thing is when we're trying to think about tracking people or individuals, or just understanding the system of those with Alzheimer's and dementia-related diseases, we have to understand that while there is the medical track where a lot of people go, there is still a whole other informal track where people do not touch our healthcare system. And we have to be, and understanding how do we even begin to build a platform or some type of pathway where people will feel comfortable enough of engaging so that we can get a more accurate account of what is happening in the system when people are not connected necessarily to their healthcare provider, or just doing it on their own, whether it may be cultural norms and things of that nature that we don't necessarily accurately capture. So those are my thoughts.
That's a really good point.
Yeah,
really good point. If you don't darken a physician's door, you're not going to get into a traditional surveillance system.
Yeah, those are great points, Representative House, and I agree with you, Pete. We can all, I'm sure, think of so many people who are doing it at home and caring at home or don't have access to health care. So how do you account for those? So great points there as well. Okay, well, one thing that I was thinking as we put this on the share drive, I'm wondering if we should maybe just put a little asterisk or something by those points that we specifically want the consultant to address, along with our own comments. Is that overkill, or is that just something? So at some point, maybe then we compile a list out of all of these points.
The share drive is our friend, so everyone will go to the share drive.
Right.
Okay. I think that I kind of viewed the whole thing as being, kind of being a report or a direction to the consultant. That these are things that in our minds we came up with, and that might be a starting point for them. They may have other things as well, but I don't know that we need to asterisk them. I think they're all
Okay.
they're all things for the consultant to look at. They may say, "Oh, this is not really that pertinent," but put them in front of them.
Sounds good. Okay, anything else with number 4? We've got about a little less than 15 minutes here on our schedule today. Any other comments or questions on that? Okay. So number 5 is the type, cost, and availability of dementia care services. So it's looking at existing resources, services, and capacity relating to the care of individuals diagnosed with Alzheimer's disease or related dementias. So again, I would think we've got lists of facilities. We've probably can find that information between all of the resources that we have, but what other input would you guys like to add to that? Jean, do you need me to look at yours?
Yes, thank you, Leanne.
So you have families, support groups, education and respite services, individuals, in-home assistance, issues if individuals live alone, home health, passport, adult daycare, assisted living costs, assisted living private pay, the average memory care rates for the first quarter of 2021, about $7,065 a month. The waiver payments would be around $2,000, about a little under $2,200 a month, plus approximately $750 a room and board paid by the participant. We have to look at assisted living availability, and then you had from ODA and Scripps in their last longitudinal study in 2018 showed 233 all memory care or memory care units in AL, but have indicated they feel it would be much higher in the current study. New figures may be available in this June or July from Scripps because the study's going on right now, as you had mentioned a little earlier. Of 791 licensed assisted living facilities, 395 are certified waiver providers with 871 memory care units certified. And then also another point was nursing home care.
I didn't put in much on the others because I'm not as knowledgeable in those areas.
I was going to ask if you'd pulled since you were in the report, if you pulled the SNF data, but
no, I didn't, Pete. But the curious thing, and the reason I put in so much, which may have been a little bit of overkill, but the in terms of the private pay memory care and the assisted living waiver memory care, that's the reason. In fact, Leanne, did I have a total? Well, no, I guess I didn't put that in this report, but there are way more assisted living waiver beds certified in Ohio than actual participants. Right now, to the best of our knowledge, and it's really hard to get because it's muddled up with Medicaid as well as just ODA. The ODA numbers are real solid, but the Medicaid numbers, I'm having great difficulty getting solid ones there, only because they show more certified providers than ODA shows. So who's to know exactly? But actually right now there are about 6,638, to the best of my knowledge, assisted living waiver participants. But yet there are 18,000 in some certified beds. So I only put that in to note the problem in the waiver payment.
Right.
And what that does to participation, especially on the memory care side, in a memory care unit.
I'm sorry, Gene.
there's lots of capacity.
Whoops.
Yes.
Alex,
There's more capacity than utilization, and that's a feature of reimbursement.
That's, yes, that was a conclusion I was going to state, Gene. So thank you.
Oh,
Right,
you're
right
welcome,
away.
Pete. I always enjoy the opportunity to help you.
You know, one of the things when I was thinking about this point in regards to the cost and availability of dementia care services, two things I thought, I mean, that's a really broad statement. I mean, a lot of these have really broad statements, and I just wonder for the report if we should somehow, or with the consultant, acknowledge that vast array of type, cost, availability of dementia care services. You know, I can think of, like, there's a teeny tiny town in my area called Delta, Ohio, that has this wonderful little church that has a wonderful volunteer run adult day program for people with dementia. You know, that, and I think there's lots of little places all around the state that provide great support to a small, you know, community. You know, that, you know, I think it's going to be really hard for us to track and to assign a cost to, but somehow capturing the availability of those resources around the state, or acknowledging that they exist, but then also maybe defining what it is specifically we want to hone in on. Because, I mean, I think just with nursing home and assisted living alone, those are pretty big tasks. And there's so many layers and complexities to it. And not that I want to negate other services, but I'm having a hard time wrapping my head around, you know, how we can do this. You know, I'm thinking we're just going to have to do it in bite-sized pieces. But I just, you know, wonder. I just have been thinking about that a lot as we've been, you know, I was going through these statements, trying to figure out, you know, how to manage this process, but also then not, you know, lose out about, like, this wonderful little day center program in Delta, Ohio, that provides a great service to a small community that probably wouldn't have a day center otherwise, you know? So I'm struggling with that a little bit. So I just wanted to, and I don't know what the consultant's going to do with that, but I just, you know, think those types of conversations are important to have too, because they all fit in. So,
Well,
I think,
you know, I think
it
Sally,
would be good to your point. I think it would be good to kind of list that sort of thing out. I mean, because on the one hand, I mean, we do have the various services that are available in Passport, one of which is adult day, as you well know, and you know, and that there could actually be, you know, quantifiable, you know, there could be numbers for that. I mean, we could say the agent can tell us how many people are participating in an adult day in Passport, but that doesn't capture the rest. Like you said, the little church in Delta is undoubtedly not in Passport.
right.
You said it was all volunteer. So, you know, I think if we could identify not the individual places necessarily, because that would be huge, but at least identify services that we collectively are aware of that are out there that aren't captured in the governmentally funded world, because the governmentally funded world is pretty, you know, is pretty quantifiable. I mean, someone can tell us, and you know, I know there's complexities, as you said, with, you know, AL and skilled nursing. You know, what's really a dementia care unit or a memory care unit, and you know, how many people are really in it, and how many people are getting cared for outside of those units, and all of those kinds of things. But it's even way more complex to try to list other kinds of things. And if we just, I think we could do the best we could in at least identifying them, and maybe the end result ends up being, we know these are out there. We don't know how many there are and where they all are, but you know, we know that they're there.
Oh, sorry. I think part of that is captured in those original huge numbers that when they talked about unpaid.
Yeah.
You know, caregiving staff, the Alzheimer's Association, and what I put in the shared drive. I think an awful lot of those things are captured and incredibly important. Because as I said earlier in the comments, I don't think realistically we're ever going to be to a point where it can all be paid for that we're going to have government payment of all the care for Alzheimer's that's going to need to happen or should happen.
I think that the point is recognizing that those things exist in the context of this larger work, and that they are a resource and they are doing great things for the people in those communities. And yeah, they're captured in the overall numbers, but I think we need to shine as much of a spotlight on them as we can, because I think they're an important part of the whole fabric of services.
I agree with that, Pete. Very important.
I agree as well. I'm all just great comments, and again, good information. I'm looking at our timing here. It looks like we've got about 4 or 5 minutes. So I don't know if you want to continue on and start delving into number 6, or if you want to talk about the next meeting, and I'll take that information from the group. How you guys, if you want to, I don't know if we have enough time to start. Number 6 is dementia specific training requirements for employees of long-term care facilities. Again, that could be another lengthy discussion. So
are there any? No, I'm just being for real. Are there any?
Yes.
There are some, yes.
Yeah.
Oh.
I think I listed them, Representative House, at least for assisted living, once again, simply because that's what I'm most knowledgeable about in the shared drive.
So maybe that's something we could all kind of look at for, Jean did give some great information. I'm happy to read that if you guys would like me to, or again, in the essence of time, I want to be respectful of everyone's schedule.
Maybe we could wait for the next meeting, and those people who had knowledge about any of the training in other settings, etc., could provide it and then discuss it.
Yeah, I think there's some in home health too.
I mean, I just was unaware of them for when I was going through all of this, all of those points.
Right.
So maybe we should just move on to the next meeting. At least we did more than last time.
Right.
Yes, thank you.
You can see that one of my goals is to move us through this.
Well, and that's a good goal. That's what, I think
should be all of our goal. Yeah.
We've had some great discussion today, and I certainly appreciate everybody's input. So I guess what I'm hearing is we're going to go ahead for the next meeting, because I was looking at the numbers for our homework, but we'll start with 6, because we didn't get to 6, 7, or 8 today, and I think those were the last ones we were going to try to get through this meeting. So we'll start with 6. Does that sound good to everybody? And then I had, besides 6, 7, and 8, we still have 9, 11, 19, 21, 22, and 28. Am I accurate on that?
I think so, yeah.
What were those numbers again, Leanne? I'm sorry.
No problem. 9, 11, 19, 21, 22, and 28. I was looking if I have those correct.
Maybe we should be a little more realistic, since we still have 3 from the last to go over, and just maybe take on 4 more and hopefully try to get through those. Hold 22 and 28 till the subsequent meeting.
Okay.
That's just a suggestion, Leanne.
No problem. That's good. So we would do 6, 7, and 8, and then are you suggesting 9, 11, 19, and 21?
Yes, and then hold the others. I mean, it'll kind of be I'm not sure we'll ever even get through that many next time, but maybe it's more realistic.
Okay, that sounds good. So if everyone has an opportunity to look through those topics and put your comments on the shared drive, accordingly. I think that will help. So we'll start the next meeting. We'll pick back up with number 6 and then move on. So next meeting, what kind of date would you guys like to look at? I know that next Monday is our main task force meeting, correct? At 10?
10 to 12, I think, Leanne.
Okay. So do you guys want to try to meet again next week after that, or?
Yeah, I could do next Tuesday.
I could too.
I can too. Next Tuesday at 8 again.
Yeah.
Yes.
That works for me. Is that anyone else on the call? Is that time okay?
Yeah, that time works for me as well.
Okay. So we're gonna go with Tuesday, April 27th at 8 a.m. the next capacity subcommittee meeting for the task force. Alex,
I'll go ahead and share. I'll share an email invitation here momentarily, so everyone will have that for a week from today.
Wonderful.
Would you be so kind, Alex, is to put the shared drive address on that too?
Oh, absolutely. No, that's a good call, Pete.
I've not even looked at it, and I'm sure the address is in there. So obviously it's in there somewhere from the past, but that would be simplify things.
And is there anyone that would like to volunteer to take the minutes for the next meeting?
All I can say is I'm free. I have my time.
I'm happy to take if either Sally or Representative House would like to facilitate.
And I can take minutes too, either way.
I'll do the facilitation for next Tuesday since we're just going to rotate that way.
Great.
Okay. So Representative House will facilitate, and Sally, do you want to do minutes, or you like
Sure.
to do that?
Sure, I
do-
can do the minutes. Yep, I'll do the minutes next week. Yep.
Wonderful. Sally will do minutes. That's great. Is there anything else for the good of the committee that anyone would like to talk about before we adjourn? Okay, so I will ask then for a motion of adjournment.
I move we adjourn.
Jean moves. Second?
Second.
Is that you, Pete?
Yep.
Okay. All right, we are officially adjourned from our meeting today. I hope everyone has a great rest of your day and week. Thank you so much.
Likewise.
Leanne, great job.
Bye-bye.
Bye.